Welcome back to Neuroblastoma Parent Global Symposium 2022. My name is Gregory Sizikov. I'm Guy's dad, and I'm on board of directors of Band of Parents nonprofit. I will be moderating this session entitled Anti-GD2 Antibody Therapy, an Important Approach in the Treatment of Neuroblastoma. This is being delivered by Dr. Robbie Majzner, Assistant Professor of Pediatrics in the Division of Hematology and Oncology at Stanford University School of Medicine, and by Dr. Juliet Gray, Associate Professor and Consultant in Pediatric Oncology at University Hospital of Southampton. Before I hand it over to Dr. Majzner, I'd like to draw your attention to the chat function on the right of the screen, where you can submit your questions directed to Dr. Gray or Dr. Majzner or to the floor. And you can do it anonymously if you choose. Questions will be addressed after the presentations have concluded. Over to you, Dr. Majzner, to present on preclinical work.
You're just on mute, Robbie.
How's that? All better?
All good.
Okay, let me just share my screen. Hi, everyone. Thank you, Greg, for the introduction, and nice to be here today. You guys can see the screen? Well, I don't hear
We can see it. We can see it.
Okay, so I'm going to talk today a little bit about the history of anti-GD2 as I understand it from reading in the literature, and then some preclinical work about new approaches that leverage the biology of what we understand about this molecule. So, GD2 is what's called the glycolipid, and basically it's got part of it that's a fat that sits in the membrane of the cell, and part of it that's a sugar that sticks outside of the membrane. And it was actually in 1982, two different groups really identified GD2 as a target. One in San Diego, and one in Dr. Paulson's lab, and one Lloyd Old's lab at Sloan Kettering. And the gangliosides were some of the first GD2 and its related molecules were some of the first cancer targets that were ever really identified. And no one's really understood fully why cancer overexpresses or has a lot of this sugar on its surface. But pretty early, different groups identified that this could be treated. So both in San Diego from Ralph Reisfeld's lab, and then the work from Naikun Chung, using different antibodies to target GD2. This was in preclinical mouse models, and the one that came out of San Diego was CH1418, and the one that came out of Dr. Chung's work was 3F8, which now actually have both led to FDA-approved antibodies. And the first studies of these antibodies were exciting, that it was an immunotherapy that was working in a pediatric solid tumor, and these actually remain the only approved immunotherapies for a pediatric solid tumor. But what stood out in all of the studies was that the antibody didn't really work. Neither antibody really worked when you had a big bulk of disease. So a solid tumor mass, lymph nodes, etc. It really only worked with what's called minimal residual disease, so bone or bone marrow disease. And this is some work from the Sloan Kettering group, where they saw initial activity in patients who had bony lesions and patients who had bone marrow involvement. So what this led to is designing studies around the type of activity that we had seen from, or that investigators had seen from this antibody. And so in the early 2000s, the Children's Oncology Group ran a randomized study of patients that had been induced to a remission or a near remission with chemotherapy, autologous stem cell transplant. And then they were randomized to either get anti-GD2 antibody with retinoic acid, which was the known kind of maintenance therapy at the time, versus patients that got retinoic acid alone. And what you can see comparing these two curves, the red and the blue, is that the patients that got anti-GD2 had much better outcomes, had 20% higher event-free survival at 2 years, and what ultimately ended up in longer survival rates, higher survival rates from this disease. And this led to the first FDA approval of an anti-GD2 antibody. Now, more recently, naxitamab, which is the humanized form of 3F8, also got an FDA label, studying in a different setting. And that was really done by studying it in patients who had relapsed neuroblastoma, where the disease was only in the bone or bone marrow, because that's where we know these antibodies can actually regress disease. And they showed clearly that a sizable portion of patients around 30 to 40%, could have regression of their lesions, regression of their disease that was in the bone or bone marrow. And for that, they were granted what's called an accelerated approval by the FDA. So now we have 2 drugs that are available to treat patients. So the biggest kind of, I think, the biggest advance with anti-GD2 in recent years has really been led out of the Children's Oncology Group by Raj and Modi, who found, actually kind of accidentally, because it was really a control group in a randomized arm where they really didn't know that this would work so well, but that when they combined anti-GD2 antibody, in this case dinutuximab or Unituxin, with chemotherapy, they saw really great response rates in patients that otherwise often seemed unresponsive. So they were either refractory, they weren't responding to their chemotherapy, or they had relapsed neuroblastoma. And this since has become, this combination has become really the de facto standard of care for patients who have their first relapse of neuroblastoma. And then even, another exciting step has been the work from St. Jude that's now leading to more trials in the Children's Oncology Group, that using another anti-GD2 antibody that's very similar to dinutuximab, if they used it up front with chemotherapy in newly diagnosed patients, they saw really great remission induction rates. So about 15% of patients who are diagnosed with high-risk neuroblastoma don't respond to upfront chemotherapy. And this study seemed to have been able to take all of those patients and get them to respond to chemotherapy. So very high remission induction rates and really good outcomes from this initial study. This is a single center study. It was about there were 64 patients on the trial, but this is now going to be followed up in a randomized fashion by the Children's Oncology Group. So to kind of summarize the clinical experience, anti-GD2 antibodies are active in neuroblastoma. This was discovered really 20 to 30 years ago and led by several groups pushing these drugs forward in clinical trials for kids. But their activity was largely limited as single agents. Combining with chemotherapy is now shown to be highly active, especially in patients who have refractory disease. We don't exactly know why this works well together, but people are really moving ahead and trying to integrate that into the upfront treatment of all patients. And then the last thing is, we don't understand resistance to anti-GD2 antibody. We don't understand why 30% of patients who hit a remission, get anti-GD2 antibody, they'll still relapse after that. And we're working on trying to figure that out. So I'm going to talk kind of 2 preclinical stories that my lab has worked on that we're trying to bring forward, or have brought forward, or trying to bring forward to the clinic. The first is talking about this don't eat me signal, CD47. So tumor cells have ways to evade the immune system. And one way they do it is they overexpress what we call a don't eat me signal on the surface on their surface, and that inhibits macrophages. So macrophages are immune cells that usually will see a cell that's coated with an antibody, let's say an anti-GD2 antibody, and eat that tumor cell. But by expressing CD47, the tumor cell is basically saying, don't eat me. And so Irv Weissman and Robbie Majzner at Stanford had made the first antibody that could block that interaction, and that leads to tumor cell phagocytosis, or eating of the tumor cell by macrophages. So they have had some promising data in lymphoma with adults combined with another antibody, and we said, oh, that's cool. Let's see if we can enhance anti-GD2. So here we took mice that had engrafted neuroblastoma and gave them only anti-GD2, only anti-47, or the combination. And you can see that neither the GD2, GD2 is hardly effective, CD47 alone has no effect. We really cure these mice by combining. And we said, well, this is interesting, but would that be true of any antibody? And so we went back and we tried another antibody. This was one that recognizes another target that's expressed on the cancer cell, B7H3. And what we saw was there was no synergy between CD47 and B7H3. So there was something specific about anti-GD2 that was driving the synergy. And the first question we asked is it possible that GD2 itself is interacting with immune cells? And so anti-GD2 is more than just a tag to remove the immune cells, but actually blocking something that might be inhibiting immune cells. And so we worked with a lab that studies sugars that coat cancer cells, and started looking if there was a receptor for GD2, if there's something expressed on our normal human immune cells that interacts with GD2. And this could give us an answer both of something that we can interrupt, but also tell us, why do tumor cells express GD2 so much in the first place? Because we don't really have such a good answer for that. And so through a complicated set of experiments, we were basically able to find this specific receptor known as Siglec-7 that's expressed on macrophages and NK cells. And that receptor sees GD2 and inhibits the immune cell activity. And you actually can block that interaction when you give anti-GD2. So what this basically has led to is our realizing that just like CD47, GD2 is also one of these don't eat me signals. The tumor cell expresses GD2 because it can inhibit macrophages and NK cells through this receptor Siglec-7. And when you block that with dinutuximab or 3F8, you actually can both drive anti-tumor activity against the tumor, but also get rid of this inhibitory signal, so you can push it even harder. So to sum up that kind of story, GD2 we think is also an immune checkpoint molecule, and it can suppress macrophage and NK cell activity. We're trying to tip the balance between pro-phagocytic or eat me signals and don't eat me signals for pediatric cancer that we hope will unleash anti-GD2. And we're studying this in patients both with osteosarcoma and neuroblastoma in the clinic now. And this study is open at about 12 centers across the United States and Canada. So, something that emerged when we were doing that studies is we saw that sometimes we can culture cell lines that are tumor cells in a dish. Sometimes they could be expressing high levels of GD2, and sometimes they could be expressing lower levels of GD2. And we just wondered if the amount of GD2 on the surface really matters. The way we assess the amount of GD2 right now on patients, actually, we can hardly do it because there's not a kind of certified way to identify the amount of GD2 on patients. And the way we do look at it in research studies, it's really hard to quantify. So we don't really understand how much heterogeneity there is in patients when you have high GD2 and low GD2. But there is data emerging from the Children's Oncology Group and elsewhere that patients in response to getting anti-GD2 plus chemotherapy seem to be downregulating the amount of GD2. And what we see here in our experiments in a dish is that the amount of macrophage activity that you have against the tumor cells in response to the antibody dramatically decreases when you have low GD2. So this nightmare of a schematic basically describes how GD2 is made in the cell. And I call it a nightmare because it reminds me of organic chemistry, which I think isn't a good time for any medical student. But GD2 is down here. And basically, you got to go through 5 steps in order to get from this sugar fat substance to make it into GD2. And the last step is carried out by this enzyme, which we call GD2 synthase. And everyone kind of assumed that the level of GD2 on neuroblastoma cells would be dictated by the amount of GD2 synthase. And so Min Huang, who runs our biobank at Stanford, just took some neuroblastoma lines that had some cells that were high and some cells that were low. And she looked at this within those populations. Is it GD2 synthase? And what she found was it's not. There's no difference. This is a complicated figure, but there's no difference in the amount of GD2 synthase. And instead, it was this other enzyme, which is ST8-SIA1, which is called GD3 synthase. And I'll show you that in a second. For this project, we teamed up with Kim Stegmeier's lab at Dana-Farber, and it was led by a really great postdoc there, Nathaniel Mabe. And they found the same thing. They looked across 25 cell lines that were, GD2 high versus GD2 low, and looking at sequencing, same thing. It's not GD2 synthase in red. It is GD3 synthase. So this tells us that the bottleneck is 2 steps from GD2. When you have low GD2, it's up here. It's the level of this enzyme. So you kind of get stuck here. So, we ended up getting kind of into complicated biology about how the cell regulates the amount of GD3 synthase. And there's a new field, a newish field of biology over the last 10 years called epigenetics. And this is really about how the cell makes a gene available for transcription and translation, for making a protein. So the cell can regulate how much of any protein it makes. And it turns out that the way it regulates the amount of GD3 synthase is through something called trimethylation of histone 3. And it's basically a complex mechanism that the cell has to make the DNA available to make this enzyme. And the cell can, it seems when you have GD2 low neuroblastoma, it basically closes this, this locus, so it doesn't make it available, and you have low GD2. But what's cool is in recent years, people have made inhibitors to these mechanisms of closing the DNA. And so you can give a drug that reverses this process and opens the DNA back up. And that's exactly what we found here. So this is in a mouse that had a GD2 low neuroblastoma. And you can see in red, if we don't treat, we see no GD2 on the surface. But when we give tazemetostat, which is an FDA-approved drug that's approved for lymphoma and another type of sarcoma, you actually express 800 times the amount of GD2 on the surface. And what that means is that when we have these GD2 low cell lines, we can start getting dinutuximab to have activity. So usually, the cell has no GD2 on its surface. You give dinutuximab, it's no different than the control mice. You don't control the tumor at all. But when you give tazemetostat and dinutuximab, you see here really nice anti-tumor activity of anti-GD2. So to conclude this, and I'll then just show 2 more slides of data, we think the amount of GD2 may be an important feature in determining the response to the antibody. We don't know why some patients may have more GD2 and some may have less, and we really haven't done a good job of defining how much that is, and we really need to do better at looking at our patient samples. We're lucky that there's this drug out there, tazemetostat, that's already FDA approved, has been tested in kids, and it seems capable in mouse models of reversing GD2 downregulation in neuroblastoma. And it's just a nice example if we start understanding more and more about our antigens, we can change the way we, change our immunotherapeutic approaches and come up with new things we can bring to the clinic. So we're hoping to eventually bring a combination of the ZH2 inhibitor with anti-GD2 and chemotherapy to the clinic as well. Now I'm just going to switch gears to another disease for a second and talk about this disease DIPG, which is this universally fatal pontine brain tumor that happens in young children. And I bring it up here because it's actually driven by a mutation in that same histone, in that same epigenetic gear I've been talking about. And we've known, we had discovered, working with Michelle Manji's lab, who had discovered that GD2 is high on this disease, and we've now translated CAR T cells to the clinic for this disease. We always knew that GD2 was high, and now we really understand why it's so high. These patients have a mutation in that regulation mechanism, and the mutation basically does the same thing as that drug that I showed you, tazemetostat. They basically make this regulation mechanism non-functional, and so they get really, really high levels of GD3 synthase. So it's cool to see kind of complementary biology from disease to disease, and also really understand why the targets are there on our cancers. We built on work from Martin Poulet and Malcolm Brenner, and then many other groups who've run GD2 CAR T cell trials in neuroblastoma to now bring GD2 CAR T cells forward in DIPG. And we've been quite encouraged by some of the responses. This is a patient we presented at AACR, a 17-year-old who is now 18, has been 16 months with a complete response to IV and then repeated local infusions of GD2 CAR T cells. And this is also results from a 30-year-old patient who, when we met her, she couldn't walk independently. She was stuck in bed on narcotics and a lidocaine drip and incontinent because of her large spinal tumor. And she had about a year near remission from this really dreadful tumor. So excited about GD2 CAR T cells. We're excited that the biology here is what drives GD2 expression, but we also think these CAR T cells are likely going to be effective in some way in neuroblastoma as well. Really exciting data coming out of Franco Locatelli's group in Rome that's been presented at multiple conferences, and now we have a GD2 trial that's open across multiple, GD2 CAR trial for neuroblastoma that's also open across multiple centers in the US. So to conclude, anti-GD2 antibody has been the one thing that's probably most revolutionized the care of children with high-risk neuroblastoma in the last 20 years. And it took 30 years of preclinical and clinical development that was specifically focused on this rare childhood cancer. And I can't emphasize that enough. GD2 is expressed on a bunch of cancers, but the antibody only ever worked in neuroblastoma because it's pretty heterogeneous in the other cancers. And it's really only through the work of pediatric groups that kept pushing this antibody, pushing clinical development, that led us to be able to have a drug that is very unique in that it's a specific immunotherapy for a pediatric solid tumor. We think that studying the role and regulation of targets like GD2 can help us develop additional immunotherapies and understand from where we get resistance. And then just in general, I think, pediatric drug development is almost never going to happen in pharma until the agent's been de-risked, meaning we find an active agent that is working in the clinic. And it's really a responsibility of the pediatric oncology community, especially the researchers and the doctors, that we keep pushing drug development within academia in order to prevail cures for our patients. And then once we see response, we know that that can be taken up both with, Unituxin, Dixitamab, Kymriah, CD19 CAR T cells for children. We know that industry will step in at that point. So just to acknowledge many groups who are involved in that research, and then also many people who are involved in the clinical trial for DIPG, and then especially our patients and their families. Stop now, and I apologize if I went a few minutes over there.
Thank you, Dr. Majzner, for the insightful presentation. And now over to the second presenter, Dr. Gray, to present on clinical trials targeting GD2.
Good evening. It's lovely to be here again. What I'd like to try and do in the next 15 minutes is give you an overview of the clinical trials that have been conducted and are being conducted for anti-GD2 antibodies. So as Robbie's talked about, GD2 is found on almost all neuroblastoma cells, and GD2 antibodies bind specifically to the surface of this. And the aim is that they bring in the immune cells of the patient to come and kill the neuroblastoma cell. There's several different anti-GD2 antibodies that are used clinically, and these are the four kind of major ones here that I've listed. The first two, dinutuximab and dinutuximab beta, are very closely related, but have been developed in parallel on different sides of the Atlantic by different companies, but have a very similar background and structure. Humanized 3F8 was developed in Memorial Sloan Kettering and is now marketed by Y-mAbs, and is slightly different as a humanized antibody. And then the last antibody has been generated to have a mutation in it, which is designed to try and make it interact differently with the immune system to have less side effects. But as to date, there's never been any comparison of these antibodies in different trials, so we don't know which is best. They all have subtle differences between them, but there's no clear one which is better or worse than the others. So as Robbie mentioned, anti-GD2 antibodies have been part of the standard of care treatment of neuroblastoma for over a decade now, since this major study was reported by the Children's Oncology Group in the United States. And in this study, children with high-risk neuroblastoma who had received their standard treatment, their chemotherapy, surgery, high-dose chemotherapy, and had a good response, were either completed their treatment with standard therapy with retinoic acid, or they were given additional anti-GD2 with interleukin-2 and GM-CSF, two molecules which stimulate the immune system. And the trial showed very clearly, this is at 2 years after the trial, 2-year follow-up of the trial, that patients who had the immunotherapy, the chances of relapse at 2 years were about 20% less than those who hadn't had the immunotherapy. So really major difference between the two groups. And this result really changed practice across the world. That was the early follow-up for the study. When the follow-up for these children who were treated on the trial were followed up slightly longer, the curves between the two, the children who've been treated with and without the antibody, started to close. So the early follow-up is the black line at the top, which is children who'd had the anti-GD2, and the red line is children who hadn't. And you can see there's a very clear difference between those lines, and that's the difference in relapse rate between the two. As time went on, the green line is the longer-term follow-up of these children who'd had anti-GD2 therapy, and the purple line below it is those who'd had standard treatment. And with time, those lines closed slightly, suggesting that in some children, rather than actually eradicating the neuroblastoma completely, you're just delaying relapse. So although this was a major breakthrough in treatment for neuroblastoma and became a standard of treatment, there were some limitations. Most obviously that still a large number of children relapsed and were not cured, and so we needed to do better and improve the treatment. But also this treatment came at a price. There was pain because this GD2 molecule is also found on the nerve cells of these children. And so when children were given the antibody, they had significant pain requiring morphine infusions, and also other toxicities that were related to the immune effects of the antibody. And so they needed to be in hospital during the infusion. So over the decades since then, there's been a lot of different studies, both in America and in Europe, to try and improve the treatment and also reduce the side effects. And things we've learned from then, firstly, that there's been big studies conducted in Europe by the Symposium European Neuroblastoma Research Group, which have shown have used dinutuximab beta or Qarziba rather than the dinutuximab, which was used in the original COG study. And that showed very similar, though it's not a direct comparison, the results were very similar. And overall, when you look at the data from children who'd had the antibody compared to those historically who haven't, there's about a 15% reduction at 5 years in the number of relapses. So it definitely has a benefit, but as I said, we need to do better. The second thing that we've learned from studying it in Europe is that having the interleukin-2 injections as part of the treatment makes the toxicity, the side effects more significant, but doesn't improve the response rates or the outcomes. And so that's been dropped from treatment in Europe and I think in the States as well. The third thing that we've learned is that by slowing down the infusion to give it as a continuous infusion over 10 days, you reduce the side effects and reduce the pain considerably, such that many children can receive it as an outpatient with either just oral morphine or no analgesia at all. And finally, the biggest breakthrough really has been that it's been rather counterintuitively realised that combining chemotherapy with the anti-GD2 seems to be a very powerful way of treating this disease. And Robbie's already alluded to these studies. The first one by Rajan Modi, where by temozolomide and irinotecan cancer chemotherapy was given with dinutuximab and GM-CSF, and showed in a very small randomized study, which is shown at the top on the right, there was a very considerable difference between those patients who just got the chemotherapy arm with temozolomide and those who got the anti-GD2 plus chemotherapy. When this was then expanded into a larger number of children who got just the antibody and chemotherapy treatment, and overall those children with relapsed neuroblastoma had a response rate of just over 40%, which is very encouraging in this group of children. And subsequent to that, there's been studies from the group at St Jude's and also from the Memorial Sloan Kettering group with different antibodies showing also very impressive results when antibody is given with chemotherapy. Most recently in Europe, we've looked in the BEACON Immuno study at the benefits of combining dinutuximab beta with chemotherapy. So the BEACON study was a platform study which was open across Europe since 2013, and initially set up to compare different chemotherapy arms in children with relapsed neuroblastoma to try and work out which chemotherapy regime was best to give to children with relapsed neuroblastoma, and also to test whether there was any advantage of giving the anti-angiogenic agent, an agent which stops the growth of new blood vessels, bevacizumab, to children. And it's a rather complicated design, got a factorial design where children were randomized both to which chemotherapy and also to whether or not they were given the bevacizumab. Ran over from 2013 to 2018, and when the first part of that completed, because of the emerging data coming from the States showing the benefits of giving chemotherapy with anti-GD2, the study was modified to look at giving anti-GD2 with chemotherapy. The first part of this study, the BEACON study, where it looked at bevacizumab with chemotherapy, showed that giving a particular chemotherapy, either irinotecan or topotecan with temozolomide, was more beneficial than just giving the temozolomide alone. And it showed that adding bevacizumab also improved the response rates and survival. Although this study was not designed to look at individual arms. The one particular arm, bevacizumab with irinotecan and temozolomide, or BIT, looked particularly promising. That's the top line here on this curve. Though we have to be cautious in interpreting this data because of the design of the study, it certainly warrants looking at in further studies. So in 2019, when the bevacizumab randomization was closed, the study was amended to look at whether giving anti-GD2 with chemotherapy would be beneficial to children with relapsed neuroblastoma. And those children who were allocated to just the chemotherapy arm, if they relapsed during the period after the trial, were allowed to cross over to receive chemoimmunotherapy as a salvage treatment. And these are the results from the study, which were published or kind of released this year and presented at ASCO. And in this curve here, the top line is those children who'd had dinutuximab beta anti-GD2 with chemotherapy, and the line below is those that had chemotherapy. And you can see there's a very clear difference between the curves, and the number of children who had not progressed 1 year after the start of the treatment was almost double in those who'd had the addition of anti-GD2 to their treatment. And equally, the response rates between the two groups were significantly different, with almost twice as high a response rate in those children who'd had anti-GD2 with their chemotherapy. If you look at this curve on the right here, it shows those number of children who are alive from the start of the trial, and you can see the curves look very similar. And that's because those children who relapsed during their treatment were allowed to switch across to give chemoimmunotherapy as crossover treatment, and therefore it suggests that they were salvaged and that they responded to treatment with that chemoimmunotherapy, which is also supports the efficacy of it. The trial wasn't designed to directly compare the bevacizumab or BIT chemotherapy regimen with the dinutuximab beta plus chemotherapy regimen, but these are the two curves here side by side. At the top is the BIT, and at the bottom is the dinutuximab beta plus chemotherapy. And you can see the top lines of each are not vastly dissimilar, and so it suggests that we need another trial to compare these two to find out which is the better of the regimens. So at the moment, although giving chemoimmunotherapy is showing considerably promise, we don't know whether or not it's better than BIT. And actually BIT is easier to deliver. It requires shorter amount of time in hospital, so if it's just as good, it would have some advantages. So far we know about chemoimmunotherapy that it improves response rates. The side effects of doing that seem to be manageable. It's very difficult to compare the outcomes of different trials because they use different inclusion criteria. So some trials only allow children at their first relapse of neuroblastoma, or only allow particular selection criteria, and some trials are more broad. So it's very difficult to compare the response rates in different trials and know whether one regimen is better or better than another. We need to have a randomized trial to know how chemoimmunotherapy compares to the BIT regimen that I've talked about, and that will be tested in the next European relapse trial, BEACON 2, which is in preparation at the moment, and we hope will open sometime next year. We also don't know whether there'll be further benefit of adding bevacizumab to the chemoimmunotherapy regimen, so putting all the agents together, and that will also be tested in BEACON 2. As Robbie mentioned, people are also testing giving chemoimmunotherapy as frontline treatment, and there's already some very promising results from Sarah Federico, which have been presented, which show very good response rates to initial frontline treatment when dinutuximab is given with chemotherapy as induction treatment. And both US and European studies are planned to test that further in a randomized setting. As well as giving chemotherapy with anti-GD2, there's possibilities of combining anti-GD2 with other things, and Robbie's already talked about combining with anti-CD47. What I'd just like to mention briefly is combining anti-GD2 with another antibody, nivolumab, or anti-PD1, which is an antibody which, rather than bind directly to neuroblastoma cells, binds to cells of the immune system and boosts the immune system and enhances the body's own natural response to cancer. And that type of antibody has been widely used in adult cancers such as lung cancer, melanoma, but on its own doesn't seem to be effective in childhood cancers, probably because childhood cancers are not as intrinsically foreign to the immune system as cancers such as lung cancer. The MiNivAn study is combining 3 different things. It's combining anti-GD2 with the anti-PD1 and also with MIBG therapy or targeted radiotherapy. And the aim of that is, as well as directly killing neuroblastoma cells by coating them with anti-GD2 and being killed by cells in the immune system, you'll then enhance that with the anti-PD1 antibody and then further enhance it by the immune effects of giving radiotherapy in the form of MIBG. So this study, in addition to this, there's been small number of case reports whereby nivolumab or anti-PD1 has been given with anti-GD2, dinutuximab beta, to patients who've already relapsed, having had either chemoimmunotherapy or anti-GD2 alone, and then had responses when it's given with anti-PD1. Which is, although it's small numbers, is very encouraging. So the MiNivAn trial is a phase 1 study, so an early phase study, the main aim of which is to test whether it's safe and tolerable for children to have these 3 things given together. It will look and see whether there's any evidence of it working, looking at responses in these patients, and also whether we can tell by the immune makeup of the patients who respond, whether there's anything that can predict response. And then we'll also looking at the serial blood samples from patients to see whether we can detect the immune effects of the therapy. The study is designed as a dose escalation study, so all patients get the same dose of MIBG therapy at the start of the treatment. They all get the anti-PD1 or nivolumab every 2 weeks, and then each cohort of patients gets an increasing dose of anti-GD2 so we can be sure that it's safe and tolerated. So the first cohort of patients didn't get any anti-GD2, they just got the MIBG and anti-PD1, and that was well tolerated. The second cohort of children got a half dose of anti-GD2 and with the other agents, and that was well tolerated. And we're now on to the third group of patients who are getting a full dose of all 3 treatments. And that shows a schematic of how the treatment is delivered, with the MIBG treatment initially, and then the anti-PD1 and the anti-GD2 given over a 6-month period. So the study is open to patients with relapsed or refractory neuroblastoma. It's open both in the UK and in the US at Madison in Wisconsin, and is opening soon in Germany. And we've so far recruited 23 patients across those sites and on the final cohort of patients. We've had some interesting responses in there, but it's too early yet to say whether those are more than we'd expect from any of the agents on their own. So to conclude, what we know about anti-GD2 is that it improves, given as maintenance therapy, it improves the outcome of children with high-risk neuroblastoma and is now considered an international standard of care. We know that chemoimmunotherapy improves response rates in children with relapsed refractory disease, and it shows promise in upfront treatment. What we don't know is which of these anti-GD2 antibodies is best. We don't know whether there's any benefit in giving anti-GD2 repeatedly. If we're giving it induction, is there benefit in also giving it maintenance and relapse and keep on giving it repeatedly? And we don't know whether chemoimmunotherapy can be further improved by the addition of other agents such as anti-CD47. And we don't know whether combining with other agents will also, it can be used to increase the effectiveness. So finally, I'd like to end by thanking all the people who have, the children and families who put their trust in us in these, to take part in these trials, and also the huge number of charities and agencies who have helped support and run these large collaborative studies. And with that, I will finish. Thank you.
Thank you, Dr. Gray, for the very informative presentation. I'll now share questions from the audience with the speakers. So question 1, great presentation, Dr. Majzner. Does including high expression of GD2 pose a danger of increasing neuroblastoma tumor cell proliferation?
It's a great question. GD2 has been linked in some studies, in preclinical studies in mice, and the dish, and maybe the cell expresses it in order to be able to grow faster. So I don't know that that's ever been shown in people. It's possible that it's true. Usually we would think about treating a relapsed population here where the disease is already growing fast, but definitely possible. That's why we do clinical trials.
Question 2, how do you test for GD2 density? Is this done through biopsy at diagnosis or relapse?
Sure. So, the way to do this in a laboratory would be to get a fresh sample from the tumor, kind of mash it up so you can get it into single cells, and then we can stain it with antibodies and run it on a machine known as a flow cytometer. But I want to say that this would be a scientific research endeavor because no one's been able yet to associate this with outcome or with whether or not, just because a patient has low GD2, we wouldn't say that patient shouldn't get anti-GD2 antibody. If they have no GD2, we might think differently, and there have been some cases of complete GD2 loss. But there's a way to do it, and you would want to do it, theoretically, we would want to do it at relapse so we understand what it looks like after patients have already seen anti-GD2.
Question 3, am I understanding correctly that tazemetostat can reverse the effects if a child has become resistant to dinutuximab? And if so, would it also work the same for those kids that have used 3F8 and tested HAHA positive?
So there's different types of resistance to immunotherapies. HAHA is when the body creates an antibody. It's human anti-human antibodies. So the patient's own body creates an antibody against 3F8. And this also happens with CH1418, and it's called HACA. And tazemetostat wouldn't affect that. There may be some ways to ablate that using other immune modulators, rituximab, chemotherapy, things that Sloan Kettering has worked on previously, but this wouldn't.
Question 4, if there is a response, but it's very slow to immunotherapy in refractory disease, could the potential addition of tazemetostat, in theory, help speed up the response?
Yeah, potentially. I don't know if the pace of the response is a predictor of ultimate outcome. But I don't know if it's any more likely to make it faster or just make it a more complete response. And it's also, I should say, this is research we've done in mice, and it also could have no effect for patients. That's why we need to do a clinical trial.
Question 5, how soon will tazemetostat be incorporated into current trials?
Well, we're working on it now, but I don't have any timeline for that, unfortunately.
Next question, is finding that tazemetostat upregulates GD2 change the current trial using dinutuximab and magrolimab?
No. If we eventually found that magrolimab was effective by combining with anti-GD2, and that became some kind of backbone that we were working with, I think our next thing that we would want to do is add chemotherapy. So I think we'd probably study tazemetostat in a separate setting for that and try to bring things together if we got lucky enough that multiple agents that we had studied were effective in clinical trials.
Okay, question 7, have you looked at anti-GD2 combined with anti-CD47 and chemotherapy, or was it just anti-GD2 and anti-CD47 on its own?
Yeah, we only did it on its own. We have a grant very nicely from Solving Kids Cancer now to support studies with a group in the UK, also with John Anderson, to see if adding it to chemotherapy also will help.
Question 8, this is maybe to Dr. Gray. Are there any emerging findings from the MiNivAn clinical trial?
No, it's quite early. I mean, we've had some interesting responses in patients taking part in the trial, but two of the agents, so MIBG therapy and anti-GD2, can cause good responses on their own. And what we're looking for is whether we can improve the number of children who respond by putting the three agents together. So I think we have to be cautious about the number of patients we've treated so far in drawing too many conclusions.
Next question, Dr. Majzner, any early results from the anti-GD2 plus magrolimab trial?
I don't have any results now that I can share. I'm sorry.
Question 10, can anti-GD2 therapies cause gastroparesis, gastritic delay as a result of nerve disruption in the tract/stomach?
Juliet, you want to?
I'm sure it can. I mean, the GD2 can cause peripheral neuropathies and kind of either kind of transient or permanent damage to nerves. And I think it's rare, but I'm sure it can happen.
Next question: if GD2 is an important target in both neuroblastoma and DIPG/DMG, should clinical trials be combined in these patient groups?
Yeah, it's a great question. You know, DIPG and DMG occurs in the central nervous system, and the antibodies like dinutuximab and nixitamab, when we give them peripherally, don't cross into the central nervous system, unfortunately. So it's really a different it's really a different way that we need to administer drugs. You know, we use CAR T cells because they can cross into the central nervous system. And we're also mostly giving those CAR T cells locally. So, you know, for now, unfortunately, we have to keep them separate. It is easier when we have clinical trials, when we have more patients that we can enroll, because these are all rare diseases. But because of the different compartments these are in the body, it would prevent us from really being able to do effective trials together.
Next question: when will chemoimmunotherapy trial in frontline open in the UK?
Okay, so there is a plan for a European pilot study of upfront chemoimmunotherapy, which UK will take part in, and we hope will open early in 2023, so early next year.
Question 13: is dinutuximab with nivolumab a good combo to treat resistant disease?
So I think I don't think we could go as far as saying it's a good combination. It's a promising, and there's been case reports. So in preclinical work in the lab, in test tubes and in mice, it looks like a promising combination. And there's been case reports of patients who've had good responses to the combination who haven't responded to anti-GD2 on its own. And it will be tested further in their MiNivAn trial. And I think it certainly warrants further investigation, but I think it's a bit premature to say it's a proven good combination.
Question to both doctors: can you comment on whether you think that vaccine trial makes sense after immunotherapy phase to continue to harness the immune system for lasting remission?
Shall I go first, Robbie? So
Sure.
I think that there's definitely rationale for vaccination. You know, that given that giving antibody infusions as proven benefit, then generating a patient's own antibody response by vaccination, there's rationale for that. And there's certainly some interesting data from the bivalent vaccine study. What's really tricky is because you have to test that in patients who have no measurable disease, they're in remission. And you don't know what's going to happen to that patient if you don't give them a vaccine. You have to have a really well-designed trial to look and see whether the vaccine is making any difference. And you need quite a large study because, you know, by the time children have got to the end of treatment and are in remission, the chances of relapse are much less than they were at the beginning. And so you have to have a really well-designed large study to look and test properly whether the vaccine is effective. But I think there's definitely rationale for testing that.
And I'm going to say it in a less eloquent way. We need randomized trials. The vaccine may prevent relapse and it may do absolutely nothing. We don't know yet. There's some interesting immunologic correlates that indicate there is an immune response, but we don't know if that prevents relapse. And the only way to find it out is to do a multi-center randomized trial of this agent. We should stop doing, it is important to do early phase trials to understand safety and potential efficacy. But when you have patients that are in remission, unless we do randomized trials, whether it's the vaccine or DFMO or other agents, we have no idea. And I think science and medicine are difficult, and that's why we have to do randomized trials. So I just will put out a plug to, I think that it is an interesting concept. It causes likely no long-term harm on patients, but we don't know if it's doing anything, and we need a trial to answer.
All right, thanks. Looks like we're at time. Thanks, Dr. Majzner, and thanks, Dr. Gray. Thanks for everyone watching and for the questions. We are at the end of the session. If you missed it, there will be a video on demand right here on the event platform to watch. And right after this, we have a presentation with Dr. Daniel Morgenstern, who will summarize today and playing a video tribute for children affected by neuroblastoma from around the world. Thank you.